Hello there, my name is Miriam Harley and I'm the Upper GI CNS at King's College Hospital in South London. On behalf of my colleagues in the region, I'm going to present our data around the use of the Edinburgh Dysphagia Score, or EDS, in the 2-week wait pathway. Many thanks specifically to consultant Boo Hay, who has greatly supported this work. It is true that dysphagia should always be considered a serious symptom, but what is clear, and most of us will agree, is that the suspected cancer pathway picks up very few actual cancers for what is quite a high burden volume of endoscopy. Patients are also subjected to concern about their symptoms while waiting for the procedure. During the COVID-19 pandemic as of last year, the BSG endorsed the use of the EDS to triage and target upper GI endoscopy for patients at highest risk based on work done in a large validation cohort in Edinburgh itself. The EDS is based on age, gender, acid reflux, site of dysphagia, weight loss, and overall duration of symptoms to produce a cutoff score of 3.5 for likelihood of finding cancer as a cause. We wanted to see if the EDS could be used in our patch to reflect a very different patient population that we have here in South London. We prospectively scored patients with the EDS who had been referred for upper GI endoscopy with the key symptoms of dysphagia on the suspected cancer pathway across 5 South London hospitals. Importantly, we did not use the EDS at this stage to justify not performing a scope on the pathway, but just to collect data and outcomes. Through the pandemic, we collected data on 240 such patients, with roughly half being from a non-white ethnic background. Our results are, we think, quite convincing. Overall, people that scored more than 3.5 on the EDS scored well above the cutoff with a median score of 8. So there were really no equivocal cases. In this cohort, we found 20 cancers, which is 8% of the total cohort, while we didn't find any cancers in the EDS less than 3.5 group. We did, however, find other significant conditions in the EDS less than 3.5 group, however, still statistically significantly fewer than the EDS more than 3.5 group, 28% compared to 41.7%. These included conditions such as reflux esophagitis, Schatzki rings, hiatus hernias, benign strictures, and eosinophilic esophagitis. What this tells us is that the EDS can be used to safely triage patients with dysphagia as a presenting symptom. They can be diverted from needing investigations on a suspected cancer pathway, but we do recognise that they still need evaluation and investigation. The chance of finding significant pathology remains high. If we had used the EDS to do this, we would have found those 20 cancers in just 115 OGDs instead of the 240 we did. As you can see, this significantly increases the value of the pathway and makes us much more effective than we currently are. Our next step is to discuss this with South London, as well as Pan London, how best to use the EDS in routine clinical practice, whether this be that GPs add it to their assessment or whether a low intensity clinical assessment, such as a telephone clinic, could be used to access and reassure patients, as well as directing them to a more appropriate pathway. Thank you very much for listening, and we look forward to your feedback.